Welcome to the Misconceptions podcast, a podcast about leading a healthy and more mindful life. I'm very glad here to have today with me Dr. Demos Michaelides, a Cambridge medicine graduate and a consultant radiologist at Everest Medical Center. Today, we will be talking about the different types of imaging, their uses, and the common misconceptions that are surrounding this field, such as, do X-rays increase the risk of cancer? How are you, Dr. Demos?
I'm very well, thank you. Thank you for inviting me to your podcast.
I'm so glad you're here with us today. I want to begin by telling us a bit about what a radiologist does. How is a normal day in the life of a radiologist?
Okay. Well, a radiologist has a number of different tasks during the day. Obviously, different radiologists will do different types of modalities. By modalities, I mean X-rays, ultrasound, CT, MRI. So I personally do mostly cross-sectional imaging. That's MRI and CT. Okay. So one of the tasks is to supervise a CT or an MRI list. Okay. At the same time, you have a list of patients who already had their scans, so you need to report on them. Okay. Mm-hmm. And that involves actually collecting the clinical information, why they had the scan done, what's actually needed from the scan, the clinical question to be answered. And at the same time, you have to collect the previous imaging. Okay, so you compare to previous imaging with the current scan, and then you do your reporting. Usually what we do do voice transcription, okay, or voice recognition, depending on the radiologist's preferences. And then we check our reports and we authorize them. Okay. At the same time, another task is to write the protocols. By protocols, I mean basically you give instructions to the technologist who does the scan, how to perform a scan. For example, if it's an MRI scan, you tell them that you need, for example, a standard MRI brain protocol. Mm-hmm. And you add in various other sequences according to what's the clinical question. Same with CT scan. You write a protocol on how the CT scan needs to be performed, if the patient needs to take any preparation before the scan, okay? And you check, because most of the patients may need to have intravenous contrast given, okay? You need to check for any contraindications. Intravenous contrast is basically it's a dye. It's mm-hmm. It's an iodine-based contrast, which is given this is for CT. Okay, mm-hmm. Is given to the patient to enhance the contrast resolution. By contrast resolution, I mean the different degree of grayness, okay, of the organ. So if it's a very highly vascular organ, it would light up. Mm-hmm. on CT, okay. If we want to do an angiography, we give arterial phase CT, and we can look at the aorta and its branches.
What's the difference between an MRI and a CT scan?
Okay, an MRI scan does not involve radiation. Okay, mm-hmm. It's a magnet essentially. Okay, and the physics behind it, in simple terms, is that you actually put the patient in a magnetic field, okay?
It's the big tumbler thing that you go in and makes a lot of sound.
It's the tunnel, yes.
It's the tunnel.
The terrible tunnel. You put the patient in, and because our bodies contain water, mostly water, mm-hmm. and it's based on the proton. The physics between the MRI are based on the proton. So the proton spins around in a particular frequency, okay, mm-hmm. depending on the organ and the density of the substance that you find the water inside. And what the magnet does, it gives a radio frequency pulse and aligns all the proton atoms in the same direction. Okay, mm-hmm. So this is just a pulse, and then it's taken away. The pulse stops. So these protons relax slowly back into their normal physiological frequencies and directions. By doing so, they return a signal which is received by the MRI and is translated into a picture. This is the most simplest way I can explain it.
Okay. And it's the one that I'm guessing it takes longer than the CT scan.
Yes, the MRI is composed of sequences. Okay, you have to tell the machine, okay, that I need you to start from, for example, an axial T1 weighted sequence. Okay, so you have to predefine the plane, axial, and also the type of sequence. And you do a number of sequences. For example, in the brain, you will start from an axial T2, move to an axial sort of flare sequence, etc. Okay, so you do 5 or 6 sequences, for example, and each sequence takes about 2 to 3 minutes, depending on the sequence. So in order to complete the examination, you need more than 15 minutes. If you're going to give IV contrast, which is a different contrast in MRI, it's gadolinium, then it takes longer.
Okay, so that means the patient is going to be, let's say, in the MRI machine for about 15 minutes.
The least, and for longer examinations, it can be up to half an hour or 45 minutes.
What happens with people that have claustrophobia?
Claustrophobia, yes, it's a bit of a problem. Okay, I mean, obviously, we start with reassuring the patients that it's nothing to be worried about, that there is no radiation. If they feel comfortable with somebody else, somebody of their immediate environment to be in the MRI with them, we can do that. It's not a problem because it's magnetic field. There's no radiation for the.
I think this is important to make it clear. It's
Yes.
no radiation. MRI is no radiation. Yeah.
And then we offer them the option of having a sedative pill, so to relax them. Okay. So such as lorazepam or something.
They don't go to sleep though. It's just relaxing.
Yeah. No, it's just an anxiolytic basically, and that helps a lot of people. So that usually works. But in cases there are some people who, they're clearly claustrophobic, they can't do it even with the anxiolytic. Then if it's absolutely necessary to do the MRI and there is no alternative modality, we will do it under anesthetic, general anesthetic.
And there's going to be an anesthesiologist in the...
Yes, we have MRI compatible anesthetic equipment. Okay, because you cannot take metal inside, ferromagnetic metal inside.
Because
they'll be drawn to the magnet. Yeah.
And because the magnet's spinning, it will destroy the machine, I'm guessing.
No, there are. If you look on the internet, there are still some horrible pictures of different medical equipment stuck into the MRI magnet.
Wow. Yes. I think I've seen one of those videos. They just get, they got a metal chair and they put it in an MRI.
Yes, and trolleys because you always have to check before you get someone in the MRI. Also, we check the patients themselves because some patients may have undergone different procedures, pacemaker, for example, coiling of aneurysms in the brain, cochlear implants. Some of especially with the pacemakers, some of the devices, the more recent ones are MRI compatible. But again, you need to check with the vendor. You need to check what field of MRI, the strength of the magnet is compatible with. For example, it can be compatible with 1.5 Tesla MRI, but not with a higher field 3 Tesla MRI. So you need to check these things before you get the patients into this.
What about broken bones and but when they fix them with metal, platinum, and stuff like that?
They're usually fine.
That's fine.
Yeah, they're not. They are titanium, so they're not sort of drawn into they're not ferromagnetic. But the only problem with those is that if you want to image the specific area where the metal is, you won't get good pictures because there is artifact from the metal. The metal actually obscures the picture, so
it's surrounding, not only like the part where the metal is.
Yes, yeah. So you just get a black sort of image and very little distorted image in the periphery.
I'm guessing in that case you do a CT scan.
Yes, and even with CT, sometimes you get artifact from the metal. We call them beam hardening artifacts. But you try and opt for the modality that will give you the least artifact.
Could we talk a bit about CT and X-ray and?
Okay, CT and X-rays involve electromagnetic radiation. Okay, which means that obviously you have to be using them where it's indicated. Okay, and you have to use as low sort of radiation as possible to give you the answer. Okay. There are some principles in radiology which we all as trainee radiologists were taught about radiation protection guidelines. Okay, there is what you call the ALARA principle. It's basically as low as reasonably possible or permittable. And basically you have to adjust your protocols, whether it's the CT protocol or the number of X-ray views that you request, so that you can answer the clinical question by doing the minimum radiation exposure to the patient. Okay, and that's very important. It's all a matter of weighing the benefits to the risks. Okay, so the benefit to the patient is obviously to get a diagnosis from the scan. The risks are the risks from radiation. Okay. Now we can talk a little bit about the risks of radiation if you want.
That would be
we put it into context on our everyday life, okay? Because we are all subject to radiation, whether we know it or not, okay? There is cosmic radiation from sort of outer space, okay? And there is radiation from metals and from natural decaying radioisotopes in the environment. Okay, so for example, radon gas. Okay. So we're all subject to radiation.
Let's say if you go to Chernobyl,
there'll be more.
Yeah.
But even also, if you live in certain parts of the world, there is more background radiation. Okay, than other parts.
Do you know any of these parts?
I was told that in Cornwall there is higher background radiation. So it's a lovely place to be. Just bear in mind, just go for visiting.
Don't buy a house.
Basically, we're all subject to we measure radiation in millisieverts. It's the unit of radiation.
Okay. Yeah.
The background sort of radiation that we're all on average subject to is about 2 to 3 millisieverts. Okay. Now, if you're going to have a CT head, okay, the radiation you will receive is about that 2 to 3 millisieverts. Okay, so you could say everybody's having a CT head of the brain on a yearly basis.
Okay.
If you're having an X-ray, the radiation is much smaller. It's about 0.1. A chest X-ray, 0.1 of a millisievert. Okay, if you're having CT abdomen pelvis, you're approaching more into sort of 5 millisieverts, 7 to 5 millisieverts. It all depends on the protocol, and also depends on the body habitus of the patient as well.
Which means,
if you're a larger patient, okay, they will receive more radiation because the parameters on the scanner will need to be changed, okay, such that we can actually have a good diagnostic scan. Because obviously there is more tissue for the X-rays to penetrate. And also there is also the aspect of radiosensitivity of different organs. Okay, for example, the bones are less radiosensitive than other organs, such as the abdominal organs, for example, or if you're doing a CT chest in a woman, the breast is radiosensitive. Okay. So you have to bear that in mind as well.
So we're talking now about really low values of radiation. But what happens when people do X-rays often? What happens?
I think overall X-rays are not much of a problem because, as I said, the dosage from an X-ray is quite low. It's with the CT scans
that you have the problem. Even if you do like 15, 17 X-rays, or is there like a limit that they say?
if you have to do them,
Yeah.
if it's clinically indicated to do them, yeah, you have to do them because the benefit would be greater than the
That's
risk.
what you said before.
Yeah. But for CT scans, if you can use alternative modalities, for example, if you can use MRI, for example, which doesn't involve radiation, or if you can do kind of interim ultrasound scans, you can find other ways of maybe following something up. If it's a matter of following a lesion up, for example, a lesion in the liver, you can follow it up with ultrasound. You don't have to do CT or even MRI.
So when people say, "Oh, I'm going to do an X-ray and I'm afraid I'm going to get cancer," that's total.
Yeah, it's not. It
doesn't sound.
Yeah, it's true. I mean, obviously going back to the risks of radiation, one of the risks is that it can cause mutations in the DNA and induce cancer, and we know that from patients who maybe at a younger age they had radiotherapy, for example, which are much higher doses of radiation, that they can actually have cancer induced from the radiotherapy.
What values are we talking about with radiotherapy?
It's much greater. It's like tenfold and more. Yeah. I don't know exactly the values because I'm not a radiotherapist.
What about pregnant women? Is there a contraindication?
Yes. Yeah. We always ask female patients in the reproductive age whether there is a chance of them being pregnant first. And also we aim to do the scans within the first 10 days from the first day of their last menstrual period. Okay, so that's a period where they are unlikely to have conceived. Okay, so we try any elective appointments, we try and program them during that time period.
And the reason being is because
we don't want to be X-raying, a pregnant lady, because obviously there'll be effects
on the fetus.
On the fetus, yeah.
What about fertility? Does it affect fertility?
It can do, yes, because essentially, again, you can be inducing changes to the DNA of the both female and male. And where we can, we use protection. We have what we call lead aprons or lead shields. If it's an X-ray, for example, you can cover from the waist back downwards with a lead apron if you're X-raying the chest, for example. Okay. For CT, it's a bit more. You cannot really sort of do, especially if you're directly scanning that
area. You can't really
pelvis. Yeah, you cannot really exclude it. Okay. But again, it's very important to make sure you do your scans in the patients who need to have their scans done. Okay.
Do you think we're overdoing it with scans?
It's hard to say. It's easy to say in retrospect when you have a normal scan. You say, "Why did I do the scan?" In some cases, maybe yes. In other cases, we may be under investigating. Okay, so that's where the role of the clinician comes in. Okay, it's very important for the clinician to choose carefully. Okay, when to actually request a CT or an MRI scans. And I mean, what we do as radiologists, obviously we look at the clinical indication, and sometimes we challenge the clinicians back as to the, why do you want to do a CT on a 5-year-old, for example?
A healthy multidisciplinary meeting. Yeah,
absolutely. You have to have we are kind of the gatekeepers to sort of imaging, but in a good sense.
Okay? A Gandalf. Yeah.
Absolutely. So yeah, we we try and suggest different modalities. For example, if it's a child, we say, why not do an MRI? Okay, if we think that we can answer the clinical question with an MRI, we try and change it to an MRI or an ultrasound. So whenever we can, we always look at the clinical indication. Okay, and we try and guide the physicians towards the most appropriate modality. Often the physician themselves will come to us and tell us, I've got this scenario, this clinical case. What do you think is the best way to investigate them? And that's great. That's the best way to go forward, because you learn more about what's the thing that the clinician wants to know. And that's the purpose of doing the scans.
And it comes back to what you said before. It's benefit to risk ratio. Let's say he's at risk of having a severe diagnosed disease, etc. Then you're going to do it. You're going to take the risk. Could you tell us a few words about ultrasounds, and then we'll move on from the imaging.
Ultrasound I think it's a very useful kind of bedside test in a way, because first, it doesn't involve radiation. It involves ultrasound waves. Okay, you can either have the patient come to you, or there are portable ultrasounds to take to the bedside, for example, or in ITU. In the hospital setting, and it's very good for structures that are fairly superficial. Okay, for example, the thyroid in the neck, the carotids, for abdominal organs as well, for lumps and bumps in the skin or in the soft tissues. Okay, the only problem with ultrasound is for deeper structures. For example, the retroperitoneum in the abdomen, or structures or organs which contain air. For example, the lungs or the bowel. Okay, you cannot image them, and the reason is because the ultrasound waves, they need a medium to travel through. Okay, that's why you use the gel when you do the ultrasound, so there is no air between the probe and the skin. Okay, so you need a medium, whether it's water or solid tissue. They cannot travel through air, so you won't see anything in the lungs. You won't see anything in the bowel. Okay, and also the depth of penetration is maybe like 10-15 centimeters at most.
You can do heart though. Can you? Heart?
Yes, you can. But that's, again, you can see some areas of the heart. For example, the right side of the heart is less well seen. But obviously the problem with the heart is that it's also encaged it's within the rib cage. So you don't have a good
angle
window. You have to try and scan between the ribs.
Okay. That's good. Let's move on to what are some tests that people have to do routinely at certain ages?
Okay, these are overall, these would be kind of recommended by the clinician. Okay, and that would be based on the patient's sort of family history. Okay, if they have a history of some sort of cancer, for example, or some sort of pathology, then that can lead to the test. Routinely, in terms of screening, we have the sort of breast screening, okay, which the patient would sort of come forward, or they will be invited to screening between the sort of ages of usually like 37 to 73. But there aren't any sort of other screening tests in radiology. Nowadays, people are making sort of, they're trying to introduce, for example, low-dose CT of the thorax for smokers. Okay, and that's a way of like doing a yearly scan to see, because obviously there are the higher risk of developing lung cancer. The other thing that some people use is CT colonography, which is a way of screening the large bowel colonic cancer. So we're looking into common types of cancers, basically. But obviously the alternative to that, and which is most widely used, is the classical, the optical colonoscopy. I mean, in terms of prostate cancer, we do multiparametric MRI of the prostate, but that is usually recommended only if the PSA is high, okay, and you're looking for early prostatic cancer. So it's more, it's not a screening test.
Going back to the breast mammography, do they have to do it after that every year or every like 3-5 years?
It differs between different countries. Okay. Some countries recommend once every 2 years. Other countries do them on a yearly basis. As far as I know, in Cyprus, it's not done on a yearly basis. I think in the UK it's one every 3 years. I'm right. So it depends on the local guidelines.
Okay. I think that's a good summary. It's helpful to know and be aware of these things. I want to ask you something else. Let's go to what are we expecting in the near future for radiology?
Okay. In radiology, the sort of what people are trying to do in radiology is to perfect the artificial intelligence. Okay. Artificial intelligence is basically it's a learning algorithm for computers where you get the computer to do most of the work for you. It doesn't. I mean, initially when artificial intelligence came out, it was a bit scary for the radiologists because they thought, oh my God, we're going to be out of profession in a few years, and there'll be all these computers analyzing images and highlighting the abnormal bit to the clinician. So there won't be any need for the radiologist. But actually, what artificial intelligence is doing is helping a radiologist be more efficient, as well as more accurate in their work. Okay, by more efficient, I mean it helps them speed up by actually doing some steps for them. Okay, I'll give you an example. For example, you have a CT of the chest. Okay, and you're looking for lung nodules. Lung nodules, basically, it's quite, because the lungs are quite big. It can be very, very difficult to pick up, lung nodules. Whereas the artificial intelligence algorithm, okay, will highlight to you suspicious areas in the lung. Some of them will be true lung nodules, others may not be lung nodules, and you reject those. Okay, but by having the artificial intelligence, first you make sure you don't miss any lung nodules. Okay, and secondly that it has found the lung nodules for you. Okay,
saves time.
Yeah, and it actually measures them for you as well. It measures the dimensions. Okay, and it measures the volume of the nodule. Okay, so next time, let's say we find a nodule in the lung and we need to do a follow-up. Okay, next time you have your scan done, the artificial intelligence will run. Okay, and you have the comparison as well. Or you say, oh, this nodule has increased in size, 25% in volume since the last CT. Okay, now that's very. It basically saves a lot of time from the radiologist. Okay, these sort of measuring and we're not talking about one nodule, maybe like 10 nodules. Okay? So it saves a lot of time from the radiologist. So you can speed up your reports. Instead of taking half an hour to do a report, you can do it in 15 minutes.
Makes things much more efficient. And I'm guessing that's where technology, AI, and everything is going. It's how to incorporate it and like help the healthcare professionals do the job even better, but not replace them.
Exactly, yeah. And that's what the current thinking is about artificial intelligence, that the artificial intelligence, the good radiologists, let's say good, I mean, or the efficient radiologists would be the ones that will be using artificial intelligence.
And I'm guessing this is a huge part of research now.
Yes. Yeah, it's trying to sort of do it in all types of scans where you can implement artificial intelligence.
I've heard about this. There's these apps that you take pictures of, let's say, the moles that you have on your hand, and it tells you if it's, let's say, high risk to be malignant, etc. We'll see how that goes. I don't know.
This what you're actually describing is it's a similar aspect of radiology. It's called radiomics. Okay. And basically, it's trying to it's helping you to characterize a lesion by taking into account its shape, its location, its volume, etc. So it takes some morphological features of the lesion, and it's giving you an indication of whether you should take it seriously or not. Yeah.
And again, it saves time for the doctor because, okay, let's say you go to a doctor and it's nothing. Well, that's 15 minutes wasted.
Yes. Yeah, absolutely. Yeah.
So, okay, let's go to some more personal questions. I want to ask, why did you choose radiology?
Okay, I chose radiology because as a medical student, I was always challenged by that diagnostic aspect of medicine. Okay, obviously the therapeutic aspect is also very satisfying, but during the years as a medical student and as a pre-registration, I realized that actually there are some patients, whatever you do, you cannot actually find a treatment. Okay.
Yeah.
I found that, and it was a bit disappointing for me actually. And I thought actually with diagnosis, most of the times you do find an answer. Obviously, having practiced radiology for so many years, I realized that even there we fail. So yeah, it was because I found it very challenged to be the first to reach the diagnosis. Okay. Secondly, I feel radiology would help me keep a more broad spectrum contact with medicine. Okay, whereas other specialties would kind of cone in into their specialty and even further subspecializations. Okay, with radiology, you have this generic sort of background. You can always sort of have a special interest if you wish, or a subspecialization as well. Okay, but you can still do the generic work, and I like that idea of not kind of being super subspecialized in something. Although I recognize the importance of subspecialization.
Did you worry any about not having so much patient contact? I don't know, maybe this is just the misconception that we have, that radiologists are in a dark room and they just do.
Yeah, I mean, you do have patient contact if you wish, which is
if you wish. Oh, okay. That's a good bonus for people that are.
Because I find that patients want to know about their condition, okay, and they would obviously they would discuss their results with the clinicians, but sometimes they come directly to you, or they may bring another scan for a second opinion, etc. But even in ultrasound, okay, as you're doing an ultrasound scan, you talk to the patient, okay, and what I usually do is I take a history from the patient whilst I'm scanning them, okay.
Yeah.
So there is patient interaction, okay, but yeah, it's not as much as in other specialties.
But I do understand what you said before, like keeping in contact with the broadness of that medicine, the whole phasm that medicine entails, because I do feel that that once I choose something, like all the rest of the stuff you did in medical school,
yes,
it might just go to the bin, and it kind of hurts because I've done all this effort.
Yes.
But yeah, I do get that. So, who do you admire?
I don't admire a specific person. I admire different people that I've sort of come across in my life, and usually I admire people who are resilient to sort of adverse happenings in their lives. So they've been through some difficult situations, but they've actually, instead of giving up, they managed to fight it and kind of turn it round to their advantage. That's the kind of people I admire.
I was talking with psychologist Andreas Anastasiou like a few days ago, how important resilience is. What advice would you give to your younger self / aspiring healthcare professionals?
Okay, I think I'm kind of going back to my my younger self. The criteria I chose, and I would still choose, would be that what do I like doing? Okay, what do I enjoy mostly doing? Because this is something you'll be doing on a daily basis. Okay, you cannot choose something that you won't be enjoying because, let's say, there are less doctors in that specialty, so you'll be more wanted or more precious. You should go for the specialty that you like doing. Okay, and the most important thing is what you want to do. You have to do it to the best of your ability. Okay, so if you're going to do something, you have to do it well. You shouldn't compromise on that. And the other thing that I've found is that learning never stops. Okay, so you take a decision, you follow a path, and you keep building on that path. If you say, okay, I'm now a radiologist, and you sit back, gradually you'll be sort of excluded from the from the rest of the cohort because you won't be like up to date, and you have to always be there at the front.
That's very good advice, and that's what makes I think medicine for me something so amazing, this lifelong learning journey. This brings us to the end of our podcast. Thank you so much, Dr. Demos, for being here today and doing this with me. And I'm sure that people will find this helpful.
Thank you for having me, Andres.
Okay, bye-bye.
Bye.